Potash with CSMI and Isokinetics 101. Thank you for joining us for the 12th episode of Isokinetics 101. John and Daniel have brought us all the way through from this is an isokinetic machine to the different modes and resistances. And now we're going to step a little bit outside the box and talk about blood flow restriction. And then towards the end, John and Daniel are going to do a review. So hang out for the end and ask questions if you have them. Johnny, Daniel, take them away.
Hey, John, how's it going?
Good, Daniel. How are you, bud?
I'm well. I got the shirt that you sent me.
Yeah, but what's the bottom say? I can feel your presence.
That's right.
Oh, I like that. I got my belief shirt on.
I like that.
Rob, what do you have?
I have a pillow in the window. Santa.
Oh, nice. Oh, like an elf on the shelf. You have a pillow in the window. Nice. You're starting something new. I like it.
So for anybody that's watching this after the fact or on recording it, we're a week out from Christmas now. So we definitely have the spirit going.
Well, that's true.
So John, sorry, go ahead.
No, go Daniel.
Sorry.
So yeah, tonight we're going to wrap up the program. I'm going to do about 15 minutes worth of lecture on blood flow restriction training and how you can implement that with Isokinetics. Then I have a 14-minute video, and then we're going to do a wrap up after that, John and I. So if you guys are ready to get started, we can knock out our webcams to get going.
Sounds perfect.
Okay, everybody. And again, welcome to the very last episode of Isokinetics 101. This is episode 12, where we're going to do blood flow restriction training and a program review. And you've seen these slides before in previous episodes if you've watched. So you should register your clinic for free at cybextest.org. It's a free database that we're building. That way your patients and your doctors know who to send their patients to for isokinetic testing. You can go to isokinetics101.org to catch up or review previous episodes. So when we refer to something and you're not quite sure or you forgot what we're talking about, you can refer back to that episode there. And as always, go to CSMI Solutions for any of your isokinetic needs. So tonight, our shout outs are going to be to the families that support us. So on the left there, that's myself with my wife, Jamie, and my two girls. And the middle picture there, that's John and his family. And the picture on the right, that's Rob and his wife. And they've stood by us for all 12 episodes. And we just want to give a shout out to them and thank them for everything.
Hey, Daniel, can I interrupt for just 1 minute?
Yes, sir. You go right ahead.
Today is baby JJ's first birthday, my grandson's first birthday. So I want to give a big shout out to him for his first birthday. Let him know that Papa J loves him.
Yeah, John, tell us who we see in that picture there.
Well, it's me in the middle, my beautiful and wonderful wife, Debbie, to my right when you look at it, my daughter, Rebecca, right behind us, my son, Tyler, to my right or your left, he's a big boy, his girlfriend, Rachel, my other son, Christopher, on the right-hand side with his wife, Stephanie, and baby JJ at the very bottom.
And yeah. Rob, go ahead and chime in and introduce who you're with in that picture.
You guys caught me off guard. Oh, no, that's me and my wife, Clara. Not showing her the two girls who are in their 20s who asked not to be shown.
And isn't one of your girls a physical therapist, Rob?
One is a DPT in East Village, New York.
Fantastic.
She does home care and loves it. Bikes from building to building.
Wow.
So Danny, you got to do the same thing. You got to tell us about your family.
So that's my wife, Jamie. She's a hematologist oncologist at Emory University here in Atlanta now. We moved here over the summer from Nashville. And then the little girl that I'm holding, that's Lily. And then the little girl that my wife is holding, that's Ellie. So they are, at the time of this recording, 2.5 and 11 months old.
So cute.
I'm a lucky guy. Thanks.
Yes, indeed.
All right, so let's go.
All right, we're out.
All right, so our discussion topics in episodes 1 through 6, we started with history and science and then went through training applications of the machine. And in episodes 7, 8, and 9, we went over testing applications. And then in episode 10 and 11, that's when we went into the plans of care. And then tonight, episode 12, we're going to talk about blood flow restriction training and its applications on the machine, and also a program wrap up. So again, tonight, it's all about BFR. And I posted just 3 articles where I got a lot of this information from. There's a lot of research out there on BFR training. I was pretty skeptical. I waited a few years before I dove into it. Then my last employer, they were really kind of getting into it. And so I got introduced to it over the last few years through them. And as soon as I saw, I instantly thought of, hey, there's a great way that we can marry these 2 great training modalities together. So that's where I'm coming from with it tonight. Now, the lecture tonight is not meant to be a substitute for going to a course. This is for anybody who has already been trained in blood flow restriction training, and now they also want to apply it to isokinetics, or if somebody is interested in learning BFR, you need to go to a course and learn it in a full course, and then you can apply it. So tonight it's a very basic depth on BFR and is not meant to be a replacement. So what is BFR? And if I say BFR or BFRT, I'm meaning blood flow restriction training. So by occluding the blood flow to the limb, we can occlude the venous return, but we still maintain the arterial flow. So we measure the limb occlusion pressure with Doppler ultrasound. It's very precise. And you can see the picture on the right. That's the set that I use. That's the course I went to. It's called Smart Cuffs. There are many other products out there that are just as good. This just happens to be the course that I went to. But you measure precisely with a Doppler ultrasound, and then you can set the exercise pressures on these cuffs around the limb with a hand-pumped sphygmomanometer. And if you're doing upper extremity training, you're going to only use 40 to 50% of that total limb occlusion pressure. And if you're training the lower extremity, like what you're going to see in the videos tonight, you're only using between 60 to 80% maximum limb occlusion pressure. So you are not completely restricting the blood by any means. You're still going to get arterial flow in, but you're really occluding the blood flow out of the limb. How does this work? There's various pathways. The main pathway is we're reducing that venous return, and that's going to result in cellular swelling in the sarcomere. And when we swell the sarcomere, that's going to stimulate the protein mTOR. Now, protein mTOR, that's responsible for increasing protein synthesis and reducing muscle atrophy. So we're going to stimulate mTOR with this kind of training. Now, also with that reduced oxygen to the muscle, and with that reduced outflow of the muscle, that's going to allow for buildup of metabolites. And we're really talking about lactate here. So when we build up that lactate, that's going to fatigue out our muscle fibers. And you'll find out in a moment that when we train with BFR, we're only using very light loads, only 20 to 30% of a person's 1 rep max. And traditionally, if you're using that light load without any blood occlusion, you're not going to stimulate any of your strong type 2 fibers. You're only going to stimulate the type 1 fibers. But if we can build up lactate, we're going to fatigue out those type 1 fibers, and that's going to lead to type 2 fiber recruitment at very low levels of resistance. The other thing that we do when we build up lactate is we inhibit a very important protein called myostatin. Now, myostatin is a muscle growth inhibitor. So when we knock out or inhibit myostatin and at the same time stimulate mTOR, we get a very big anabolic pathway that is available to us. Now, this picture on the right side of the screen, that's a cow who the myostatin gene has been knocked out. And so you can just see the level of beefiness, if you can get the pun, in that cow there. And you can just Google online, do a Google search of myostatin or mTOR animals, and you can find dogs, mice. There's all these animals that you can see where they've either naturally through genetics or through modification, they've eliminated those genes, and you can just see the level of muscle that is brought on. And I doubt that cow is doing leg press and squats. The rise in lactate that we get, another effect it has is that the satellite cells that are present in the muscles, they're going to be activated and they're going to proliferate to the area. And we typically only see this proliferation with high or moderate to high rates of muscle damage. But again, with BFR training, we're doing very light loads, only 20 to 30% of a person's 1 rep max. So you typically wouldn't get this high level of satellite cell activation with that low level of resistance. And the nice thing is that BFR does not lead to high rates of muscle damage. So you're getting the satellite cell activation without those high rates of muscle damage. Another thing that this does is the hypoxic environment and that buildup in lactate, that's going to increase VEGF expression. That's a genetic expression. What it's responsible for is increasing angiogenesis, and this is after fracture or after injury. And if we can increase the rate of blood vessel growth, we can improve healing. And there's a lot of studies that are being done right now that are looking at, when somebody has their ACL reconstruction, and they have the graft incorporating into the tunnel, using BFR, if they can speed up that graft incorporation time. So maybe when they're done looking at that and investigating it, we'll have some good data on that. The last effect, and again, I'm just going through a very broad strokes here. The last effect that it's going to have is that you can stimulate HGH production. And that's going to lead to further collagen synthesis, whether in the muscle, the tendon, the ligament, and the bone. So the kicker here is that the training effects occur with low exercise resistance. Now, this is important because when we have somebody who's injured, and whether it's they just had a surgery or they have a muscle strain, a patellar tendinopathy, a ligament injury, they're not able to lift heavy, and we want to get them strong. So we can get the same training effects that you would get if you had worked somebody without any occlusion training. If they had exercised at 80% of their 1 rep max, that's equal to 20 to 30% of their 1 rep max with the cuffs on. And the other thing is that normally hypertrophy doesn't begin until 8 to 12 weeks after a traditional strength training program. But with BFR training, you see the hypertrophy effects occurring as early as 4 weeks. So this is a very good modality to use in your early rehab phases. Now, once a person's able to lift heavy, you want them to lift heavy. But in those early phases when they can't lift heavy, this is a way for you to accelerate hypertrophy in those early phases to really speed along their rehab. Now, the main question people ask is BFR safe? And there's a lot of research out there. One of the articles that I cited earlier in that slide was one of them. And research has shown that BFR training is safe and effective modality and has a low risk of thrombus and vascular injury. Now, having said that, all patients that you put through BFR, you have to screen them for risk factors prior to application, because this is not appropriate for everybody. And there's a whole checklist of things that, if they have this or that gives them, a point, and there's a point value system. And if they're above a certain point, then they're not a candidate for BFR training. Again, you need to go to a course and get the deep dive in on not only what I've covered so far, but the safety of BFR training. And once you've had that training, you have to adhere to the applications, the science and exercise recommendations that you learn in those courses. So what we're doing tonight, we are combining BFR with Isokinetics. All right, so the advantage that you're going to have with the dynamometer is that we can accurately measure a 1 rep max with isometric testing or with a strength test. We can precisely set exercise angles. We can set the pace of exercise. In the videos, and then when I describe each application, I'm going to talk about the pace. The pace of the exercise is very important, and it's easy to rush through if you don't have something pacing you. We can adjust the resistance of the exercise very easily. In our isometric applications, we can adjust the targets. When we're in isotonic mode, we can adjust 1 pound at a time on the fly of the exercise. And during isokinetic mode, the isokinetic mode automatically accommodates the resistance throughout the range of motion and rep to rep. And the final thing is that we can preset exercises by writing exercise protocols. So the applications I'm going to show you, I'm going to describe each one quickly, and then we'll go to a video. We're going to do two versions of isometric, and then an isotonic, and then an isokinetic. So the first one is called unloaded isometrics. And everything I'm describing for you today and in the video you're going to see is for the quadricep. Now you can certainly apply it to any muscle group, but for the quadricep, when we do the unloaded isometrics, we're going to set it up as a hamstring exercise, and we're going to put targets, and we're going to weigh the limb, and we're going to set our targets just below the weight of the limb, and then the patient's going to unload the weight of the limb off of the pad. Now, I'm going to talk to you about these, the pacing and the rep schemes. So for your isometrics, you want to have a 3-to-1 exercise to rest ratio. So we can set a 3-second hold and a 1-second rest. As far as the reps, you're going to build in your protocols a set of 30 reps and then 3 sets of 15. And you're going to go up to 60 seconds in between. So when you see something on here written 30, 15, 15, 15, that's what I mean. 1 set of 30 followed by 3 sets of 15. And then we're going to move on to a loaded isometric. And you can refer back to these after if you're, I'm going to explain a lot of this in the video, but I wanted to have a slide that spelled out everything for it. The loaded isometrics, for the quad, we're actually going to load it as quad. And this is going to be very similar to the isometric mode of exercise that you saw way back in episode 4. Now we're going to find their 1 rep max. We can either do it with an isometric test or we can do a trial rep. And we can find out exactly how much they can do at 100% of their maximal contraction. And then we just have to set our targets on the screen, 20 to 30% of that. And then you can adjust their targets as needed for fatigue. And we're going to do that same 30, 15, 15 rep sets and reps. Next, we move on to isotonic pacing, and we can use the pacing bar or the roadway application. You can refer back to episode 6 where we talked about how to set that up. Now, when we get into isotonics and isokinetics, the pace that we're going to use is 2021. That means that we're going to do a 2-second concentric with a 0-second rest at the top, then a 2-second eccentric. And for isotonic, I like to put a 1-second rest at the bottom. When we do the isokinetics, I'm going to put a 0-second rest at the bottom. We're going to still use the same 30, 15, 15, 15 set reps. And again, with this, you can easily set either light resistance or no resistance at all, and you can easily adjust the resistance throughout. And the last application is pure isokinetics. So we're going to set it up as a CPM. That's important. So when you're looking at the video, look at Rob's effort and how hard it is, because I forgot to set it up as CPM and I set it up as isokinetic mode. So if you're doing this on your machine, refer back to the slide. That way you remember to set it up as CPM, so it makes it much more difficult in isokinetic. We're going to use the same pacing, 2020. So the way we pace isokinetics is that we set our range of motion. For the knee, I'm going to go from 90 degrees up to 10 degrees. I don't want to lock out. So that's 80 degrees of total motion, and we're going to set the velocity of exercise to be half of that, 40 degrees per second. So it's going to take Rob 2 seconds to go concentric, 2 seconds to go eccentric. But again, everything we're going to do is for the quadricep. We're going to do the same 30, 15, 15, 15 exercise parameters. And the nice thing about isokinetics is it automatically accommodates to their effort. So let's go into the videos. And again, afterward, if you're reviewing this later, or if you have the handouts, you can follow along with the handout and look at the video. That way you know what we're referring to. So let me load up my video. Our model today is Rob Potash of CSMI, so I want to say thanks to Rob for letting me film him. In this first clip, I'm setting Rob up with the blood flow restriction cuff. Now you could already have this around your patient's leg and just not inflated, or you can put it on as they're sitting on the machine. Now the first 2 exercises you're going to see us perform are isometrics at 60 degrees, so I already have the machine locked in at that angle. And I've already measured Rob's total limb occlusion with the Doppler ultrasound, and I've figured out what 80% of that is so that I know what pressure to set for the exercise. So we've hit our training pressure and we're set to go. The lowest level of BFR with the machine we're going to do is unloaded isometrics at 60 degrees. And when I say unloaded isometrics, what I mean is that he's not going to be pushing up into resistance. He's only lifting up the weight of his limb. So we're essentially doing a quad set, but I have him at 60 degrees versus fully extended. So even though the amount of shear you get with the quad set and full extension is minimal, by having him at 60 degrees, it's even less. And remember, if we go back to the isokinetic quadriceps curve, 60 degrees is where that muscle can produce its most torque and it has the best mechanical advantage. And you're able to see the quadriceps activate in this position on him. And you can see he's not lifting off of the pad, he's just unloading the weight of the leg. So if we look at the biofeedback on the screen, I have it set up as isometric exercise with a target. Now what I did is when I wrote this exercise protocol, I actually have it set up for the hamstring. So when his leg is sitting on the pad, it's registering the weight of his leg. And I set the target to be just below that amount. So when he contracts his quad and unloads the weight of the limb off of the pad, that force on the screen is going to drop into the target, and it's going to allow that the target to go across the screen for the 3-second contraction. And then he gets a 1-second rest where he can just relax on the pad before he lifts up again. So he's going to do 4 sets. The first set is 30 reps, and then sets 2, 3, and 4 are all 15 reps. He holds the contraction for 3 seconds, and then he rests for 1 second. And he's going to get a 1-minute break between each set. Now this is a lot harder than you would expect it to be. So if they can't complete all 30 reps or all 15 reps, that's okay. Let them take a break. If they need more than the 1-second rest as they're getting toward the end of the set, let them. The machine doesn't start until they lift off. If they need more rest time between the sets, give it to them. This is a very hard exercise. And you're supposed to keep the cuffs inflated throughout the entire 4 sets. Now the cuffs I use do have a quick release button on the top. That way if the patient needs to get a little bit of relief with it, they can push that button and it reduces the pressure inside the cuff by 10 millimeters of mercury. So now we're going to move on to the next level of difficulty, which is isometrics with an applied load into the pad. Now when you write the exercise protocol here, you need to do it for the quadriceps itself. And I'm just showing you on the screen how you can adjust those targets up or down as needed for the patient. So the advantage is we can actually do an isometric strength test on our patients to find out exactly what 100% of their maximum contraction is. And remember, with blood flow restriction training, we only want to exercise at 20 to 30% of their maximum. So we can calculate this precisely. So this is Rob's isometric strength test that we did earlier in the day. And I have highlighted the peak torque for his left quadricep. So his left quad hit 122 foot-pounds at peak. So if we take 20% of that, that's right at 25 pounds. So that's where we can set our targets for the exercise. Another way of finding out what the target should be without doing a test is when you're in the exercise, the very first rep, have them slowly push into the pad and build up the torque until they reach that maximal volitional contraction. And again, you're not wanting them to get painful with it. At most, just minimal discomfort, 2 to 3 out of 10 is what you're looking for. And then you can take that amount, multiply it by 0.2 to 0.3, and you have your target for the exercise. So during this video and others, I want you to look at first, Rob's face. He's putting a lot of effort in, and he's only a few reps in, but watch him during the last few repetitions of each of these exercises. And you can see just how difficult of training this is. And at this point, Rob had a very minor injury to his knee. It wasn't nearly anything like a post-surgical case. The other thing to look at is the leg itself, not only to see his quadriceps contracting, but you're going to also see that the limb can start to redden or change colors, and you're also going to see some venous distension. All of that is normal with blood flow restriction training. Now, it's also normal to get some very light, transient tingling, but you're not wanting their whole foot to go numb or to have any uncomfortable numbness. If that's the case, you can reduce their pressure down in the cuff itself. So as we zoom in on his thigh, you can see the venous distension, you can see the swelling, and also the change of skin color that's present. Now, Rob can attest to this. VFR training is not comfortable. It feels like you're working as hard as you possibly can to get very minimal pressure and very light exercise out of it. Now, the third level of blood flow restriction training that we're going to do with the machine is just a pure isotonic exercise. Now, the advantages that we have using this machine is we can, one, set the pace of the exercise. When you do BFR, you want to have them do a 2-second concentric and a 2-second eccentric, and you're not supposed to put any rest in between, but I do like to put a 1-second hold at the bottom just to help them stay on target. Now I have Rob set up on level 1 feedback, so the bar that pacing bar that he has to stay in is pretty large. If you want to make it harder without increasing the weight, you can just up the level, and that the bar that he has to stay in will be much smaller. What you'll notice with people just doing pure BFR without any visual feedback is they tend to rush through because it gets very hard as you go to your 30 reps or to the end of the 15 reps of your other sets, and they will rush through. So by having a target to help them pace can help them stay on target, because you need to get those slow contractions to build up the metabolites and the lactate within the muscles in order to get the effect. The second advantage that you're going to have in using a machine is you can adjust the load on the fly. Now with this, as he gets tired, I can adjust the torque down by 1 pound at a time, and I can do it for both the concentric and the eccentric side of the contraction. If you're doing this without a machine, let's say you're just on a normal knee extension machine. Now you can easily use the pull pin and adjust their load as they go, but those typically only allow for 10 or 20 pound increases at a time versus 1 pound at a time. Now, a very common way of doing just full arc quad with BFR isn't with a knee extension machine, because that's usually too heavy for them. Typically, they're sitting on the table doing full arc quad, and you have a light cuff weight, and we'll just say 3 pounds. And they start going, they get, maybe to rep, 16, 17, 18, and that 3 pounds is becoming too much. So in order to keep them with that same pace and to get their full 30 reps or 15 reps, you have to drop it down. So they have to stop and rest while you take the cuff weight off and put the next lower one down onto the limb. So they're not getting a good set because they're getting that rest in the middle. So with the dynamometer, you eliminate that. Now the last form of BFR with the machine today is just a true isokinetic exercise. So the way that we pace this is we take the total range of motion, in this case it's 80 degrees from 90 to 10, and we set the speed to be half that amount, so 40 degrees per second, so it takes them 2 seconds to go up and 2 seconds to go down. Also, remember with isokinetic exercise, the resistance automatically adjusts. So not only rep to rep as they fatigue, but even within the repetition, where you're stronger, you're going to have more load, where you're weaker, you're going to have less resistance. Now we're only having Rob exercise his quad. He's pushing up on the way up and he's pushing up on the way down. So he's only doing concentric eccentric quadriceps. Now remember earlier in the lecture when I said to write your exercise protocol as a CPM? Well, I forgot to do that when I was filming this video, so Rob is getting smoked. When you write it as a CPM, when they need less resistance and they're tiring out, it's easier. Versus if you set it as isokinetic, as I did, it gets really hard. So just watch Rob's face as he finishes his last few reps. Another thing to keep in mind here, this is the end of the day when I went up to Boston at CSMI. So at this point, Rob has already assembled the machine. He did an isometric test. He did a standard isokinetic test. He did the interrupted stroke isokinetic test. I put the BFR on his legs and had him do a round of 30, 15, 15, 15 squats. And then we got on the machine and he filmed each of these isokinetic BFR applications. So I don't know how he's still hanging in there. That's just a level of the athleticism he has and the level of training that he performs. So he's really giving it his all here. Just remember, they don't need to complete all 30 reps or all 15 reps. Once they get to that state where that muscle's completely fatigued out, they can stop. Now that's just his drive. He says he was not going to give up and he was going to complete it. All right, Rob, if you could hop back on here real quick, we can talk about that experience that you had.
Reliving it?
Yeah, so Rob had no idea that I was going to show that video tonight. Maybe he did, but I purposely didn't send it to him before. So I remember, and if we had unmuted the live feed, people could have heard, even during that unloaded isometric application, I remember you saying that toward the end, you're like, wow, this is a lot harder than I would expect it to be. And so just give me a quick, maybe a comment about how much that sucked.
Towards the end on a scale of 1 to 10, 11.
Yeah, it's
Yeah, it was it's surprising. I'm used to lifting some weight. I train on the Cybex a lot because I can. But it was amazing how just such a light load with the blood flow cuff on, it just intensifies the workout to a level that I don't know, it would be hard to get to.
And for anybody who doesn't,
quickly.
So Rob, you guys might not know, but Rob's a CrossFit athlete, and we didn't cover it today, but one of the big applications you can use BFR with is for cardiovascular conditioning, and that's a pretty big part of CrossFit competition, right?
Yeah, that's pretty much the gist of it. It's all about work capacity.
And where do you stand right now in the competition?
Okay, now this stop. I do well.
Okay, yeah.
I'm set for the next round.
Yeah, you do.
I have nothing to do except blood flow restriction with Daniel until March.
All right, Rob, we can go ahead and knock it out and then we'll continue on.
Yes, thank you.
Yes. All right, and John, go ahead and unmute yourself because we've reached the point where we're going to do a program review.
Sounds good.
So, John, it's been a long 12 months doing this program, and it's been fantastic. You know, I haven't worked with John since 2016. And so I'm used to hearing all these concepts, you know, every single day, kind of drilled into my brain. And I haven't had that. So it's been really nice on my end, working in with him and just kind of re-energizing myself for this, as well as bringing up a lot of concepts that, you know, I've heard a million times, but, you know, I've forgotten about. So I've really enjoyed doing this program.
Well, I'm thankful for that, Daniel, because quite honestly, I think that you are hands down the best physical therapist with applications for isokinetics, not just in the United States, but probably the world right now. I don't think anyone has the level of interest and education that you actually have in all of isokinetics. I don't think there's anybody better in the world than you are right now.
I appreciate that. So I just have a couple slides that, you know, just in general, I think that I wanted to hit. So first is know your equipment, do your setups. You know, if you're only doing knee, ask yourself why you're not also using it for your ankle, shoulder, elbow patients. But do your setups at least 10 times on staff members. And here's the other thing, practice going from side to side. Because when you test somebody, they're on the machine and you have to switch side to side with them on it. You have to get used to that. And here's another thing, practice how to make little adjustments throughout the exercise. So if, you know, they're working their knee and they're saying, I got a little bit of discomfort, and you look at the dynamometer, you know, they're slightly off the axis. You know, it might be that they shifted, or, you know, during the exercise, or they adjusted a little bit. Know how to make those tiny little adjustments when you pause the exercise, and that way you can keep going. So get good with that. As far as the software, know your menus. You need to know where everything is. So go through each menu and click on every single button. Know what it does. And there's help menus all over the software. Get to know the dashboard feature. If you haven't learned that yet, the dashboard feature, you can't do testing from there, but every single exercise application that we've done is available in the dashboard. Learn to create protocols. You know, what I choose to write or work might be a little different than what somebody else might. Let's see, let me make sure I'm showing the correct screen. All right, I think you're seeing what you're supposed to be seeing now. Let me go back down. All right, I think we're up and running now. Sorry, it was only one slide. So again, know your protocol editor. That's on the bottom left of my screen here. Custom build your own protocols. Everybody likes to do it a little bit differently. So write those in. And the nice thing is once you have them there, you can find them in the dashboard. So it's a very easy way to pull those up. On the right side of the screen, this is really important. Know what every single thing is on your exercise screen. That biofeedback really enhances the exercise. That's a very important aspect. So not only will it tell you as a clinician, you can get a lot of assessment about how your patient's doing, but you can tell them what you're looking at so it can better improve their exercise. Lastly on this, know your test reports. There's a lot of different reports that you can use. Know the ones that you want to use and know how to interpret them. Don't just look at the numbers, but put it all together. John, anything else you want to add about knowing the equipment and the software?
No, I think that really brings it back to where we need it. And you know, that was one of our clinical pearls that we really talked about, is get to know your equipment, work through it at least 10 times before you put somebody on something new or different than what you've been using.
Absolutely. Yeah, you know, as far as that, you know, the test reports, when you run a test on somebody, they're going to ask you what it means, and you don't want to be fumbling around on the spot in front of them. And also, you know, when you're running through an exercise or a test, you don't want to be fumbling through the menus or fumbling through a setup. You're going to lose confidence from that patient right then and there. You have to be the expert on that equipment. The other side of this is know your patient. Select the appropriate tests and measures, and that way you can determine their rehab needs as well as their readiness for return to play. Assess them, not just with the test, but with the exercise. If you're noticing that, while looking at the screen that they're starting to shut down eccentrically, or their torque is dropping, or they're really doing this pretty easily. Maybe maybe they're ready for the next speed, or they're starting to struggle a little bit. Let's take them back from, instead of eccentric loading, let's take a break. Next time we're on this, we're going to do some isometric work. So know when to progress them and know when to regress them for each of these applications. What are your thoughts on that, John?
I'm right with you on each one of those. I think it's very appropriate when we talk about this that you've got to kind of match your patient to the type of exercise progression that you're looking to be able to do. It really comes down to, set principles, specific adaptations to impose demands. Not everybody should be getting the same exercises. We need to make sure that we're doing them appropriately for each one of the patients, and that's really what we're saying here.
One of the dead giveaways when we're doing the eccentric loading and the deceleration training, when you're seeing a high level of that, what we call the force oscillation or the eccentric inhibitions. Again, you can go back to, I think, episode 5. We talk about that there. When you're seeing that, that's telling you that that muscle neurologically is not firing well, and it needs to be trained through. And you don't progress them. You might even hold them back a little bit at that point. All right, John, let's go ahead and move on now. John, I want you to kind of be the wise Yoda to my Luke Skywalker. Let's put it all into perspective.
Well, I think it really comes down to, as we wind up, there's a lot of different programs that people can go back and look at. And I think the one area that we really need to talk about is, how do you make these functional applications for training? And that's really what it's all about if we're going to rehab somebody appropriately. So not everyone's just going to get on the machine and kick and pull as hard and as fast as you can for 10 to 20 times. It's specific to what they individually need. Are they having more neurologic deficits or more musculoskeletal deficits? And each one of those we can apply when we kind of pay attention to it. And so that's one of the reasons I talk about the proactive approach, is really finding those practical functional applications for the isokinetic eccentric training that we want to look at. So, we've gone away from concentric reciprocal training to actually looking at how do we function and what's the mode and the mechanism of injury that we see on the field from an injury standpoint. And again, most of the time when we pay attention to it, we're going to see that the mode of injury occurred in the eccentric phase of the sport.
Let me know when you want me to advance the slide.
So go ahead and advance. So, we talked about this a while back, and I really just kind of throw this back in because, again, it talks about the distance, speed, time formula, because a lot of people still get really confused when we talk about each one of these. And so it kind of puts this at, if you're looking for one thing in particular, for instance, if you're looking at speed, then it's going to be your distance over time. So you would divide time by distance, or distance by time, in order to get speed. If you're looking at time, you do the same thing. And if you're looking at distance, you'd look at speed times time in order to assume that. So the reason I put this back in here is, again, we use some very easy physics equations in the early phases. And one that I like to talk about often is force. So, what does force equal? It equals mass times acceleration. Now, every time I go to the gym, I see these guys lifting weights, and they're lifting weights, free weights, dumbbells, kettlebells, on the machines, all different types of weight aspects, but we're really talking about mass. And what are they doing? As they're able to lift 20 pounds, they go to 25, and then they go to 30, they go to 35, they go to 40. And what they're looking to be able to do is to lift greater and greater mass as they go through. But what if that injury actually occurred in that acceleration or specifically that deceleration phase, wouldn't it be really good for us if we could include that in our rehabilitation program early on in some aspects to help with neurologic function, and then increasing eccentric loading later in our rehab program when we want to return them back to function in order to accelerate their ability to be able to produce force. And that's really the key. So let's talk about the two topics that we want to go into just as a quick review. So let's go to the next slide, Daniel. And I think we skipped one. Let's go up one. Sorry, so they got switched around. So really, yeah, I want to talk about eccentric loading first. So remember what we said about eccentric loading, because these two topics are different than anything that you have probably heard before in relationship to isokinetic testing or training. We've been doing this for a long period of time. I came up with these concepts, years ago, and it really came down to, in the early phases of rehab, it's more about neurologic adaptation. How do we get the muscle to respond and to work more appropriately? And one of the things that we found is that if we remain in the eccentric mode of contraction for a longer period of time, we get a little more of that neural feedback to the muscle so that we can actually learn how to control it. That neural adaptation that becomes so important to us. So what we started talking about is, with our eccentric loading in our beginning aspects, we normally had a 2-to-1 ratio of eccentric to concentric timing, meaning that we would go 20 degrees per second in the concentric phase, but only 10 degrees in the eccentric phase. So we were spending half the time, or more than twice as much time eccentrically in the same range of motion. So again, with this example, if we said 60-degree range of motion and we want 20 degrees concentrically and 10 degrees eccentrically, it would take us 3 seconds to go up into the concentric phase, but 6 seconds to come down in the eccentric phase. So what we were really looking at is being able to respond in the eccentric phase of contraction a little bit longer period of time to give them that neural loop and teach them how to perform effectively and efficiently and eccentrically. We also know that's one of the areas that they have the greatest amount of inhibition in, especially early on in the phases. Our early science review and muscle review kind of talked about all those principles. So again, for me, eccentric loading and deceleration training become one of the more important concepts for us to go with. So again, when we set up our eccentric, we'll often say 30, 40, 50.
Oh, sorry.
That's okay. We know that that's going 30 degrees concentrically, 15 degrees eccentrically. If it's 40, it's going to be going 40 degrees concentrically, 20 degrees eccentrically, and again, 50 and 25 degrees eccentrically. So we're slowly starting to increase their speeds so that they adapt neurologically through that phase. Once we have them contracting appropriately and they're beginning to actually be able to work into that 25 to 50% of their effort, and they don't seem to have any neurologic deficits, I like going into deceleration training. So by increasing the speed of the eccentric motion, you have a tendency to increase the eccentric force production, sort of like what we saw in our force velocity curve. So again, we normally talk about a 1-to-2 ratio eccentric concentric. If we go 20 degrees concentrically, it's coming back at us at 40 degrees. So it's a much faster response. It's almost like the difference being, if someone's throwing a weighted medicine ball against you, you have to decelerate that very quickly or it's going to hit you in the face. So that's the effect that we're looking to be able to do, is to load quickly in the eccentric mode of contraction and be able to decelerate. Now, we don't want to take someone who has a deficit and have them do that, because we would hit them in the face with the medicine ball. So what we want to do is we want to train them to be able to accept that early eccentric loading exercises to bring in that muscle contraction so that we can get into deceleration training. So again, the first number always represents concentric speed, knowing the eccentric speed is going to be twice that number. So again, if we said deceleration is 30, 40, 50, we kind of mean that the concentric speed's 30, eccentric 60. If the concentric's 40, eccentric's 80, and if the concentric's 50, it's 100. And again, notice it's important that every time we increase the speed 10 degrees for the concentric speed, it doubles that for the eccentric speed. So we're really starting to have a plyometric effect in our training. And that's really what we talk about. You know, how do hamstrings get strained on the field? It's that very sudden deceleration, quads. You know, when you talk about a rotator cuff with a throwing injury, it's that sudden deceleration that we have to go through. If all we're doing is lifting mass, that's not the mode, and that's not specific to that mechanism of injury. So if there's one review that I think everyone should go back and really kind of pay attention to, it's our discussion about eccentric loading and deceleration training. And we specifically, you know, call them different things because they perform different matters. So from my standpoint, Daniel, I think that's my most important lesson of what we've been doing for a long period of time. Pass it back to you. I think that you've done a fantastic job putting these together for everybody. I've just kind of gone along for the ride to kind of help out. And I think that everything that you've done has been very impressive.
Let's go ahead and bring our webcams back on. And we can say bye-bye to everybody. All right. So, you know, for me, the goal of this program, hello, was to
Hi, how are you?
The goal of the program was to really show anybody who's been using Isokinetics.
Statue of Liberty. It looks great. What are you talking about?
That was the goal.
That was great.
There you go.
That was the goal of the program.
Hey, everybody. Hey, everybody should actually know by this time this is live.
Yes.
Yeah.
Other than, look, that was a 12-month setup for that one joke, and it paid off. No, the goal, from my perspective, was to educate everybody who's using the machine on what it's capable of doing. Because when I have conversations with therapists and I hear that they're still doing just, you know, the high speed concentric, they're not even looking at eccentrics, isometrics, isotonics, any of the different testing applications. And I felt, you know, I have this great wealth of knowledge on the machine, and I really wanted to bring that out. So that was my goal. Hopefully we've challenged your thoughts on what Isokinetics can be, and, you know, helped you to find ways to implement these changes into your rehab.
No doubt.
Yeah, and the sum total goal for CSMI in putting together the Isokinetics 101 with Daniel and John is just from early on when we started in the industry back in 1982, the machines were extremely popular, and whatever you needed an isokinetic test or some training. It went up, it went down, and then it's kind of coming around. But in working with John and Daniel and seeing all the things to do, they make you realize it's not the only tool in the toolbox. It's a piece of the pie. If, you know, if the patient was a pizza. But it's an excellent tool. And if you see someone like John or Daniel using the tool, and you watch the different ways they weave it in and they weave it out, and the results that they get speak for themselves. It's important for people to learn and to know. And the other thing we realize is that if we have a seminar, everybody comes, they learn, but the information kind of dissipates over time. So by putting it on a webinar and leaving it up there for people to recall whenever they like, you've got a nice library that you'll benefit from. Everybody should benefit from if they use it. So John and Daniel, thank you very much for this time. It's been a great 12 months. It's actually amazing that it's been 12 months. It went very quickly, but you all did a fantastic job. This is exactly what we wanted. And I invite anybody to watch it. And if you have other clinicians that want to watch it, by all means, it's free. It will always be free to watch. So hopefully watch it, use it, and your patients and your athletes get back to work, get back to the field faster.
All right. Well, thank you very much, guys, and thank you everybody for watching.
Go one more, Daniel, because I think that's one of the more important ones.
Yeah, absolutely. Well, I love this one right here. This is my favorite. Sorry. Okay, you're able to see it there, John?
Yeah. So again, you know, Daniel has a Facebook, and I would always tell you to seek him out, to start to ask questions specifically in regards to things that you want to know. And if you need an in-service, if you're looking for additional information, Daniel's the guy to really kind of talk you through some of the issues or problems that you might be having. So fantastic for doing in-services. I highly recommend that.
Thanks
Absolutely.
again.
Daniel's got a road trip
Absolutely.
next month. 2 road trips.
Even better.
Oh, yes.
Good.
Hopefully, I'll be nice and busy in 2020.
That's right. Get a backpack. That's all I'm going to tell you.
All right.
Have a great holiday season and a great
All right, guys.
2020, everybody.
All right, bye.
Cheers.
Aloha.